Welcome back, everybody, and thank you for joining the Fielding School of Public Health's Continuing the Conversation webinar. I'm Shweta Saraswat, Communications Officer at the school. Currently, 8.5 million Californians who otherwise couldn't afford health care receive benefits under Medi-Cal. This year, with the implementation of the Affordable Care Act, another 1.2 million people will be eligible for Medi-Cal coverage. In this webinar, Dr. Roby will discuss the current status of the Medi-Cal expansion and enrollment in covered California. He'll also provide an update and analysis of employer-based insurance coverage and discuss the opportunities states will have in the future to change their implementation of the Affordable Care Act. If you have any questions during this webinar for Dr. Roby, during or after the lecture, you can just type it in the field at the bottom in the chat window, and that's in the bottom left-hand corner of your screen. Okay, Dr. Roby, let's get started.
Thanks, Shweta. I appreciate it. So hi, everyone. Welcome to our Continuing the Conversation webinar for the new year, a very important and historical year in terms of health insurance coverage for the U.S., I think. So today I'm going to talk a bit about progress in terms of covered California, as mentioned, and the Medi-Cal expansion. Also touch a bit on what will go on with the remaining uninsured and what opportunities the state might have to pursue covering the remaining uninsured, either through the existing structure of the Affordable Care Act or through other mechanisms. So I'll talk a bit about an update, some of the numbers that have just come out from the federal government around covered California enrollment and the Medi-Cal expansion. Unfortunately, covered California, I believe this week, will be releasing their information on the December 28th and prior coverage, but it wasn't ready for this webinar, so we'll be using some of their older data to give us an idea of what's going on in terms of insurance purchasing, but we'll be focused on the federal data to look at the impact overall in terms of covering the uninsured. Then I want to talk a bit about using new coverage and the possible barriers that people will fall into because of the fact that there have been delays in getting insurance cards, there have been customer service delays, issues with signing up, but also people are signing up for plans that may have narrower networks than they expected, may have higher deductibles than expected, and we'll talk a bit about what those plans might look like and how people can deal with those situations. Then I want to talk a bit about regional differences in the state that I think are not all that new, but they are certainly being exposed, or consumers are certainly being exposed to these new regional markets for insurance that could differ depending on where you live in the state, and understanding how that dynamic might impact California's ability to expand insurance for everyone. And then I'm going to talk a bit about state-funded programs that are in process or have been transitioned out that will allow for more people to get insurance coverage and perhaps have a better experience than people who might just have covered California coverage or Medi-Cal coverage on its own. And lastly, we'll talk a bit about the opportunities and progress toward universal coverage focused on the remaining uninsured and what states can do in terms of their authority to make changes to the ACA or innovate within the ACA after 2017. So first, the update on the Affordable Care Act overall. I think, as Shweta mentioned, there's 8.5 million people that have at some time in a given year been on Medi-Cal, but it's important to look back at those who are uninsured most recently and think about how that might change in the next few years as people start signing up for covered California coverage, start signing up for individual market coverage that looks very much like covered California coverage, and then sign up for Medi-Cal and take advantage of potential employer offerings that might be enabled by the employer shared responsibility requirement in the Affordable Care Act. So nationwide, when the law was signed, when the ACA was signed back in 2010, the baseline number for uninsurance was about 50 million. So we've seen that situation improve slightly with about 47.3 million non-elderly currently uninsured nationwide as of 2012 current population survey. However, we have seen that employer-based insurance has gone down while public reliance on public coverage like Medi-Cal or CHIP coverage, Healthy Families in the state of California, went up during that period of time. The other thing that occurred was that the ACA in 2010 created the ability for kids under the age of 26 to stay on their parents' plan if they had employer-based coverage that covered dependents. And so that's been credited with covering up to 3 million people over the past few years. And so that caused an increase in the number of insured individuals who are younger in that period of time. Now in California, we have, according to the California Health Interview Survey of 2011-12, about 5.4 million people, or 16.5% of the population, who are non-elderly uninsured during that year at a certain point in time. So you can think about this as, if you were to get a phone call on the CHIS survey in a certain day, what would you answer to this question? So it's called our point in time estimate. But troubling for those of us who are in the world of healthcare access and studying these impacts is that there are another 5% of people who have been uninsured at some point in the year and have these breaks in coverage. So we have 4.3 million who are consistently uninsured for all 12 months of a year. But then you also have people who, about 2.5 million, who are churning on and off coverage, might have a break of a month, might have a break of 11 months in uninsurance. So we have to be aware of that population. And according to the California Health Interview Survey, there are about 6.9 million of those people who are uninsured at some point in the year, and they do have these gaps in coverage, although 4.3 million of them are uninsured for the full year. And I think they're the real target of the Affordable Care Act, but I think some aspects of the Affordable Care Act will allow fewer gaps in coverage so that people have more continuous coverage over time. Now, I wanted to talk a bit about changes to insurance coverage that we can expect. And I'm sure a lot of you are aware of the main insurance reforms that went into the Affordable Care Act, including the fact that there's now guaranteed issue coverage, meaning that nobody can be told that they're uninsurable, they cannot be charged more due to healthcare risks or health behaviors than anyone else in the market. In California, you can only rate a premium based on age, and you have to abide by a 3-to-1 rating band, where a 64-year-old would be charged $3 for every $1 a 21-year-old would be charged. And so we're seeing constraints on what insurance companies can do in terms of pricing premiums, and it is causing changes in premium prices overall. But it also provides a little bit more protection for people who have previously been uninsured, or people who might be losing insurance and have a pre-existing condition. And so I think as those things level out, we'll figure out over the next 3 to 4 years where things stand in terms of premiums, in terms of response. But we've encountered a new day in terms of how insurance is delivered in the U.S., and these consumer protections that are now available are pretty significant in the context. And I think the ACA is not only about the opening of health insurance exchanges to buy coverage and the expansion of Medi-Cal, but also about providing options to people who had previously been either priced out or locked out of the market due to pre-existing conditions, and then adding consumer protections like removing annual benefit limits and lifetime benefit limits, establishing the baseline essential health benefits package, so everybody basically knows what a typical health insurance plan should offer in both the individual and small group market, which are employers with 50 or fewer employees. So January 1st, 2014 represents the first day that people could be covered by these new ACA plans, but we're in the middle of an open enrollment period that goes until March 31st. If someone signs up by March 31st, they would have coverage effective May 1st. That would allow them to avoid any individual mandate penalty, the $95 per person or 1% of household income that you would face if you do not cover yourself and have creditable insurance coverage. Both Covered California and Medi-Cal have seen quite a bit of growth in enrollment via new applicants over the first 3 months of open enrollment, and I think a lot of leaders in California expect that to continue as we end open enrollment. In addition, we've seen some changes on the insurance side that have resulted in cancellations of people's health insurance policies that were non-ACA compliant. So these plans might have had a very high deductible, or they might have had a benefit that was, or no, benefits that were not included in the essential health benefits package, or vice versa. And in some cases, they were perfectly good plans, but they were built upon a pricing model where the price was low because people had been risk selected into that market, and that couldn't be maintained in the new world where you had to have a 3-to-1 age rating and you could not say no to people with pre-existing conditions. So we've seen about 1 million policy cancellations. 800,000 of them are supposed to go into effect by December 31st, 2013. So they've already gone into effect, and people have had to transition over to new ACA compliant policies, either in covered California or through the exchange or through insurance companies outside of covered California, buying directly or through brokers. In addition, about 104,000 Anthem policies were given a 3-month extension on the cancellation until February 28th because of a regulatory issue, and another 113,000 Blue Shield policies were canceled effective March 31st, 2014, given a 3-month extension. And LA Times recently reported that only about 20% of those in the Blue Shield policies stayed in those policies through that holiday, in essence, and the rest either went uninsured, went into the individual market outside of the exchange, or went into covered California. Now, in terms of early results nationally, as I mentioned, the Department of Health and Human Services Assistant Secretary of Planning and Evaluation came out with some numbers yesterday reporting the early numbers coming out of open enrollment effective January 1st for the entire nation, looking at specifically the marketplaces in each state, as well as the Medi-Cal coverage, as well as looking at the differences between what happened in the federally facilitated marketplaces through healthcare.gov, which have been fairly problematic, and then what happened in the states. So you can see that about 2.2 million non-elderly individuals signed up for individual market coverage through insurance marketplaces, 36 of which were run by the federal government, the federally facilitated marketplaces, and 14 states plus DC are operating their own state-based exchange. So 1.2 million actually signed up through the federally facilitated marketplace, which is a huge difference from the 200,000 they had at the end of November. So you're seeing a 6-fold increase in only 1 month as we neared the deadline to get coverage that was effective January 1st. The states had had more successes early on in October and November that were running their own marketplaces, and they saw a 3-fold increase, but still they generated about 1 million people into the state-run insurance marketplaces. Now, one important thing to keep in mind here is that these numbers do not include people who decided to sign up for individual market insurance outside of the marketplaces, which is a market that still exists, but has to abide by the same rules as the exchange marketplace. So they still have to use guaranteed issue coverage. They still have to use those same age ratings of 3 to 1 from old to young. They still have to ban annual lifetime limits. They can't rescind the coverage or deny coverage to people who sign up during open enrollment. So there's a hidden number out there that nobody really knows at this point of people who are staying in the individual market outside of the exchanges that run on the same rules, in essence. Now, we've also seen some expansion of Medicaid coverage in the states that are actually opting for the Medicaid expansion. And even in states that are deciding not to expand Medicaid, you still see people who are previously eligible for Medicaid but now find it easier to sign up for services, or maybe they now have information that allows them to sign up for services, that have created some increases in Medicaid enrollees in states that didn't expand Medicaid at all. But in a state like California, we've seen quite a significant increase in the number of people signing up for Medi-Cal through various means. Now, the 1.6 million assessed eligible for Medicaid or CHIP coverage through the state and federal marketplace does not include people who signed up for Medicaid in their state via the traditional eligibility process through a hospital financial counselor or a county eligibility worker or something like that. So in California, we represent a pretty significant number or percentage of the overall enrollment throughout the country, and actually represent more than our population. So about almost 500,000 people have now selected a plan through Covered California as of December 31st. The idea that that coverage would start January 1st or slightly thereafter, depending on whether they met the first deadline. So this is actually 4.5 times the number enrolled as of November 30th. So there's been a big increase in insurance signups in that last month of 2013. And again, we don't know how many enrolled directly through a health insurer in the individual market. So we've often heard people say, well, you canceled 1 million policies and you only have 500,000 people in Covered California. that means 500,000 people are still uninsured, and that's not necessarily the case. Many of those cancellation notices had an ability for people to do nothing and be auto-enrolled into a new plan that was ACA compliant, and it had lots of ways in which people who maybe decided they didn't want to shop through Covered California or didn't have subsidies to buy insurance would just continue to sign up directly through their health insurer themselves. And so we don't really know what's going on outside of Covered California individual market, and I'm hoping we can get some data released from health insurers soon to kind of complete that picture and really see what's going on over the entire individual market that operates in the same parallel way. Now in Medi-Cal, we've seen quite a bit of expansion, and you'll notice that it almost doubles the enrollment in Covered California. Now, of course, Medi-Cal coverage is free to sign up unless you're a child falling into the old CHIP population that was part of the Healthy Families transition. But one of the really significant factors here is that 630,000 people were already enrolled in the low-income health program, which was part of our Bridge to Reform waiver that started in 2010. And they were automatically transitioned into Medi-Cal managed care plans in each county from those locally run low-income health programs, and that represents more than half of the new Medi-Cal enrollees that have come into Medi-Cal as of January 1st. We also have another 180,000 or so that qualified via Covered California, and it looks like almost 400,000 that signed up through traditional county eligibility determinations through eligibility offices. Now again, these 1.1 million newly enrolled, the 630,000 coming from the low-income health programs are certainly in the new expansion population, but some of those almost 500,000 in the through Covered California through traditional county eligibility offices could have been people that are previously eligible for Medi-Cal but didn't enroll for some reason. And we have had an undersubscribed Medi-Cal program when you look at the total eligibles in the state for many years. So the question a lot of people want to know is who's actually signing up for Covered California, and the big question that a lot of folks ask is around the age makeup of the population. Are young invincibles signing up that are going to allow insurance markets to stabilize and make sure that it's not only older, sicker people who are signing up with healthcare needs that might cause adverse selection and premium increases? So you can see here, this is from the Department of Health and Human Services, where about 25% of Californians signing up in Covered California are between the ages of 18 to 34. 24% nationwide are fall into the same category, 18 to 34. And so this indicates that it's a little bit lower than we would want if you consider the uninsured or individual market insured, which probably represents or probably contains about 35 to 40% of people being 18 to 34. So I think California and the nation are really focused on trying to get the younger population to sign up because they are undershooting these estimates, even though they represent a good approximation of what the overall population looks like. The overall population isn't necessarily the target population for signing up for Covered California or individual market insurance outside of Covered California. Again, because this is just Covered California enrollees, we don't know what's going on with the individual market insurance outside. And because of the way the risk pools work and risk adjustment works in the Affordable Care Act, it actually doesn't really matter whether people sign up in Covered California or through the individual market outside because of the fact that they're sharing in the same risk pool. And so if younger people are signing up in droves outside of Covered California, that's still beneficial to the overall risk pool and making sure that premiums don't go up in subsequent years. Currently, in the ACA, there are protections to make sure in the first 3 years at least that any adverse selection felt because younger people are signing up at a lower rate and older, sicker people are signing up at a higher rate is balanced. So there are 3 programs. There's transitional reinsurance that would cap stop loss or would create stop loss insurance for plans in the exchange at $45,000 for the first 3 years. Also, there's a transitional risk corridor program that will last from 2014 to 16 that will compensate plans that spend more than 3% of their, if they spend 103% of their premiums on medical care, after you take out administrative costs, they would be reimbursed for those losses by plans that are spending less than 97%. In addition, there's a permanent risk adjustment program that will continue that exist in the individual market, both in and outside of the exchange, that will try to balance payments between insurers that take on risky populations and those that do not. So there are these 3 programs that are designed to kind of get us over the hump in terms of stability and make sure that premium increases aren't really significant for the first 3 years, and then we'll have to look back and see once the dust clears about who signed up and if premiums are going up in a significant way. So then it gets to what types of plans are people buying in covered California, at least right now. And again, this is from HHS data for California and the US specifically. You can see that for the most part, people are signing up for bronze or silver plans. So one important component of the ACA is that the tax credits that are allotted for people who earn between 138% of federal poverty level, around $15,900 for one person, up to $46,000 a year for at 400% of federal poverty level for one person, is supposed to buy you a silver plan. So the silver plan ends up being the basis for the subsidy calculation. And namely, it's the second lowest silver plan available in your market. So depending on where you are, if the Health Net HMO is the second lowest silver plan in your market, they'll basically calculate what subsidy you deserve based on that second lowest silver plan for the Health Net HMO, and that would be applied to any plan you choose to buy within the market. And you can either apply that dollar amount to a gold plan or platinum plan and pay an additional share. You could apply it to a bronze plan and possibly get a very low premium because the silver plan is more expensive than the bronze plan. However, if you sign up for a minimum catastrophic plan, which is only available for people under 30 or who have received a plan cancellation notice or can prove some other financial hardship, you don't get any subsidies to help buy that plan. So people with subsidies are typically signing up for silver or bronze plans because the subsidy buys them that product. So we'll probably see that most people will sign up for these 2 plans, but one of the issues is that the deductibles are substantially higher than you might see in the employer market in these bronze and silver plans. You see a similar trend in the US, however, you see that in comparison to the US, California has a lot fewer people signing up for gold plans and more people signing up for bronze plans. So I reflected on this a bit already, but I wanted to get into, if we're talking about universal insurance coverage, we want to make sure that the services people are using or the insurance plans people are signing up for actually cover what they need it to cover. Are the deductibles too high? Are the benefits too narrow? Are the networks too narrow to enable people to actually use services? So I wanted to look a little bit at if the newly insured will continue to face obstacles in terms of underinsurance or gaps in care, or they'll face other access barriers given the difficulties with sign-up, the difficulties with paying one's bill, and that type of thing within covered California and even outside of covered California. So there are currently some short-term barriers that have certainly come up in the news and in consumers' minds. One, of course, is this issue of getting enrolled as of January 1st and making a payment for your plan that starts January 1st. Now, we started with a January 6th deadline to pay your premium for coverage retroactive to January 1st, 2014. However, because of delays in processing, delays in customer service, and also extensions of the deadline to sign up for open enrollment, we've seen those deadlines get pushed. So every plan in the state except for Kaiser and Anthem are now focused on a January 15th deadline. So if people pay by tonight at midnight, they would be able to keep their January 1st eligibility and keep that plan they signed up for. However, Kaiser and Anthem have extended those because of administrative difficulties. Kaiser has extended to January 22nd, and Anthem has extended to January 31st. Anthem has come up a lot because of the fact that a lot of people who signed up for Anthem haven't gotten a bill yet. When they call the customer service line to inquire about the bill, they're told, you'll get it shortly. You might be able to get an insurance card early, but a lot of people are upset about the responsiveness with which Anthem has handled this new influx of patients. It should be noted that I believe Anthem at this point is the #1 enrolled plan in the state because they are statewide and they have a multitude of different options available. And they're also running Medi-Cal managed care plans. I'm sure the crunch of new enrollees has stretched their capacity quite a bit. There's also a lack of insurance cards overall showing an effective date of January 1st. And network lists and default primary care physician assignments have also been an issue where people still have questions to be answered around who's actually in the network. A lot of this information is now available on the health plan's website as well as Covered California's website. It actually has a select a doctor and health plan tool that guides you through the selection process. But that came on a little bit later in the game, and a lot of people are getting defaulted to a primary care physician and being asked to choose, and they're having to deal with customer service lines that are clogged up because of people who are looking for their insurance cards, trying to pay their bill. And so I think in the next few months we'll still see that crunch of volume. But we can talk a bit later about how patients can try to navigate that to make sure that they're not suffering from access barriers simply due to the fact that they don't have that insurance card. I mean, I can't remember the last time I got my insurance card on time either, but if it was January 1st and I had a healthcare need, I think consumers need to know what their rights are in terms of navigating the system and making sure that bills are paid and they're not on the hook for their spending. Now, I wanted to get a bit into cost sharing and the barriers people might face in that area. As I mentioned, most people, about 80% of Californians in Covered California, are signing up for silver or bronze plans, which either have a $2,000 deductible in the case of a silver plan or a $5,000 deductible in the case of a bronze plan. 85% of Covered California enrollees are using premium tax credits to help them purchase that coverage through Covered California. Obviously, if you're outside of the exchange buying through the individual market, you're still seeing the same silver, bronze, platinum, gold plans with the same deductibles and standardized benefits, but you're not getting premium tax credits. So there are some people out there buying completely unsubsidized coverage and paying full price. So these tax credits are, of course, available to those earning between 138 and 400% of the federal poverty level. And as I mentioned, it's dependent upon the second lowest silver plan in the rating region, but also on the household income of the individual, where people at very low incomes are getting subsidies that cap their premium spending at 3% of their household income, while folks all the way up on the 400% of federal poverty level side of the income spectrum are getting tax credits that cap their premium spending at 9.5% of their household income. Younger people, even though they might fall within those income guidelines, may not actually qualify for tax credits because of the way it establishes the ceiling. And if you never hit the ceiling, you will never get the tax credit, even though you have an affordable premium offered to you. In addition, there are some cost-sharing reductions available to people who are up to 2.5 times poverty level. And it depends on how far up the income spectrum you are. If you're earning between 138 and 150% of federal poverty level, you get offered what's called an enhanced silver 94 plan, which basically erases your deductible, makes your co-payments very low, including a $3 office visit copay. And then as you go up the spectrum, those reductions shrink, but it still protects people at lower income ranges who are signing up for these silver plans. So you can see this is data from November from Covered California specifically, so it doesn't reflect the new enrollees. So this is probably based on about 110,000 people who signed up as of November 30th, where you can see that the enrollment by metal tier is different based on whether you got a subsidy or didn't get a subsidy. The subsidy eligible sign up in much larger proportion for silver plans and bronze plans, very limited coverage in minimum plans because of the fact that you don't get a subsidy to help you buy it. When you look at the non-subsidized coverage being purchased, you can see that there's a more even mix where people are actually putting money into buying a bronze and platinum plan or a gold plan over the silver plans. So you might have a mix of people there who are higher risk, older, higher income, buying platinum gold plans, and then people who don't get a subsidy but want to pay the least amount possible for insurance coverage, and they might opt for a bronze plan with a $5,000 deductible. So the levels of insurance coverage are standardized, which I think makes it a lot easier for people to look at their options and really understand what they get for the different levels of coverage. And I think that's a good step that Covered California made. If you go to another state like Colorado, you might see 400 different plans available, all with slightly different cost-sharing variations, slightly different networks, and it could become very hard to shop. I think That's one of the reasons why the federal exchange had such a hard time getting all the data to talk to each other and collaborate, cooperate, because of the fact that there's so many plans they had to run, and it was different in each state. In California, it's fairly straightforward, and each of these types of metal tier levels are also required to be offered outside of the exchange as well. So it's becoming a lot easier for people to say, a bronze plan in the exchange is this amount of money, a bronze plan outside of the exchange is this amount. These are the carriers that I could possibly buy it from. I have the same protections in terms of out-of-pocket maximums, deductibles, free visits, and et cetera, that's available in either market. So the minimum plan, as I mentioned, is only available to individuals under 30 or those with a financial hardship exemption, including that proof of a plan cancellation notice. That allows you to basically pay the lowest premium possible. It's usually about $5 to $7 cheaper than a bronze plan in the same market. You get 1 wellness visit for free, 3 free primary care, mental health, or urgent care visits. The deductible and out-of-pocket in-network maximum are exactly the same: $63.50 for an individual, $63 for a deductible, $63.50 individual for in-network out-of-pocket max. And as you go up the generosity scale in terms of metal tiers, you see that changing a bit, where the deductible shrinks as you go from minimum down to platinum, and the out-of-pocket network, out-of-pocket max in-network shrinks as well, depending on which level you sign up for. So you can see here that the typical silver plan doesn't get you any free visits, but you get 1 wellness visit for free, and a $2,000 deductible for a single person, $4,000 for a family. But you can see underneath the Silver 70 plan, you see those enhanced plans that are available for people earning between 138% of poverty and 250% of poverty, that provide additional cost-sharing reductions. So if you're at the Enhanced 87 plan for silver, you would get a $500 deductible instead of a $2,000 deductible, and you have a lot more back-end protection, with the out-of-pocket max being set at $2,250 for a single person or $4,500 for the family. And then, of course, as you go up to the platinum spectrum, you see a $4,000 out-of-pocket max for an individual, no deductible, and of course, there's a 1 free wellness visit, but there's no deductible to potentially pay into before receiving any first dollar coverage. So in addition to the metal tier ratings, we also see variation in geography and what's available in each area. And that's one of the things that I think has always existed, especially in the group market, around where HMOs do business, where PPOs do business. But typically, the individual market tended to be dominated by Kaiser and Anthem. So they both had statewide networks that were fairly large, but they also had fairly high premiums when compared to the Covered California premiums. And one of the criticisms, of course, has been that because Covered California negotiated with these plans, and premiums ended up kind of being pushed down because people wanted to gather market share, or because Covered California was influencing the acceptability of a bid to get a qualified health plan contract, you ended up with plans trying to push premium or push reimbursement down in order to make sure they could come in at an affordable premium. And so the networks that are available in the different plans are quite a bit different depending on what region you're in, and also what type of plan type you sign up for within that brand or within that carrier. So the type of plan varies. You see HMO, PPO, and EPO coverage, so health maintenance organization, where you have to pick a primary care provider and you have to abide by those gatekeeping mechanisms. A PPO, where you have in-network services paid at a fairly generous amount, out-of-network services that are often paid at a 50% rate for the usual customary reasonable cost. And then an exclusive provider organization, which is a closed network like an HMO, but you don't have the same PCP choice and referral gatekeeping that would occur in an HMO. And so the availability of plans and carriers varies by rating region. We have 19 rating regions in the state. You'll see that Anthem and Blue Shield are in every single rating region. There are a couple exceptions of zip codes, let's say in Alameda County, where Blue Shield doesn't do business in certain zip codes, so you can't buy there. But for the most part, they're a statewide product, but they do offer different plan types in the different areas depending on the perceived need in that area or their availability of network in that area. Kaiser is also almost statewide. They're in every rating region except for Santa Cruz, Monterey, and San Benito. And then they're limited availability in the more rural regions, in regions 1 and 10. And then HealthNet is in a majority of rating regions, and then you have lots of local plans like SHARP, like Molina, LA Care, Valley Healthcare, Chinese Community that are making up additional products available in regions throughout the state. So this is a map of the rating regions, and you can see that in Southern California, the regions are pretty large because of the population, the way our counties are carved up. But in the Bay Area, for example, you have in the Bay Area, kind of that metro area, you have 5 different rating regions where San Francisco is its own, Marin, Sonoma, Napa, Solano is its own, Contra Costa is their own, Alameda is their own, and then you end up with Santa Clara having their own. So there is a chance where people who are, work in Alameda and live in San Francisco might decide to sign up for a San Francisco HMO plan, but the providers in the network do not expand into Alameda because there was no need to have them under contract, and so they're not able to go to their physician easily when they're at work, and they would have to go home to see an adequate network of people. So people need to be aware of those network differences, I think, as they make plan decisions and what plans are available to them. So there's variation by region in pricing, the plan availability, and also the carriers available. So I think you can imagine looking at all the different regions and options available can be quite dizzying, so I decided to just present a tale of 2 regions, just comparing Alameda and San Francisco as I just described. And you'll see here that there are 5 different plans available in those 2 different rating regions, but in Alameda you have 3 options: Anthem Blue Cross, Blue Shield, and Kaiser. In San Francisco you have 5 different options: Anthem Blue Cross, Blue Shield, Chinese Community Health Plan, Health Net, and Kaiser. Then you'll see, of course, that the Anthem Blue Cross product in Alameda happens to be a PPO product, whereas in San Francisco it's an EPO product. Conversely, in Blue Shield, you see Alameda has an EPO product, San Francisco has a PPO product. So the network in those 2 products may not be the same. So just because you know that there's a San Francisco doc that takes PPO Anthem Blue Cross insurance in San Francisco through a group product, let's say, if you're in the Alameda Anthem Blue Cross PPO, there's no guarantee that that person is also taking that Anthem Blue Cross PPO product. So I think people have to be aware of those network limitations. In addition, one thing I do want to point out, especially for LA buyers and Southern California buyers, is that the Health Net HMO product and PPO product are both sold in Southern California. The HMO network is very different than the PPO network. So people need to just be aware of those network differences. Kaiser, the network is exactly the same. It's always an HMO model regardless of where you are. So I think people who kind of need portability of coverage are gravitating toward the Anthem, Blue Shield, and Kaiser products, and possibly Health Net depending on where they live. But then you do have these local options that are introducing kind of interesting competition to the mix, especially in San Francisco where Chinese Community came in, and they've actually gotten 22% of the provider network or of the enrollees, and they came in as the lowest price plan in a lot of areas. So people are able to take that silver plan subsidy and apply it to buy a free Chinese Community Health Plan bronze plan, or buy a very low cost silver plan through that health plan as well. Another smaller plan that's doing pretty well is SHARP in San Diego with about 10% of the market share at this point. So you can see in Alameda, based on Covered California November enrollment data, that those who are subsidy eligible, majority of them signed up for Kaiser Permanente plans. Those who are non-subsidized are signing up more often in the Anthem plan or in the Health Net PPO. The Health Net PPO probably primarily because it tends to contract with the higher end, higher cost hospitals. So you might end up with UCSF in that network where they may not be available in other networks. In LA County, UCLA and Cedars are both in the Health Net PPO network, but not in the Health Net HMO network. And in San Francisco, you can see where Chinese Community, I believe it averages out to about 22% across both markets of subsidy eligible and non-subsidy, but Chinese Community represents over a quarter of the subsidy eligible population. So very price sensitive consumers are making a decision to take a chance on an existing plan that has a good history but is fairly narrow in terms of network, but also is coming in and trying to grab market share through Covered California. Now I wanted to get a bit into what happens with legal permanent residents? So I've talked already about the Medi-Cal population. We've seen about 1.1 million signing up. We've also seen, the 500,000 people signing up through Covered California and taking advantage of subsidies to buy bronze and silver plans, and then quite a bit of variation in terms of where they end up related to the type of plan they choose. Now, legal permanent residents bring up an interesting issue in the Affordable Care Act because technically, according to the law, they are not allowed to, if they have lived in the U.S. for less than 5 years, they don't meet the 5-year eligibility bar, and they're earning under 138% of federal poverty level, they're not technically allowed into federally funded Medicaid coverage as part of the expansion. However, California already operates a state-funded Medi-Cal expansion or Medi-Cal program, and they've decided to continue operating that state-funded Medi-Cal program temporarily to allow people who are legal permanent residents for less than 5 years to sign up for coverage and get it fairly quickly. However, they're going to be transitioning the newly eligible childless adult population out of that group and into Covered California, which is allowed under federal law. So they are allowed to get advanced premium tax credit subsidies and take advantage of the enhanced 94 plans that will be available as a silver plan. But Medi-Cal has made the decision to issue wrap payments to help people pay their own premium, their own share of premium, and also Medi-Cal will be covering benefits that aren't available in the Covered California benefit package. So that could include adult dental, things like that. So that population, even though they were somewhat carved out and marginalized in the actual ACA, California is dealing with them in a different way to make sure that they have more comprehensive care than somebody who might fall into that population outside of the state of California. So then we get to the remaining uninsured, which unfortunately will probably be quite numerous, at least in the next few years, but I think over time we expect it to shrink, assuming that Covered California and Medi-Cal continue on the path they have in terms of enrolling new people. Now, there are several populations of concern, of course, the undocumented, then, of course, the eligible but not enrolled. For example, there are several counties who didn't participate in the low-income health program, Merced, San Luis Obispo, Fresno, Santa Barbara, and Stanislaus, that may have more people eligible for Medi-Cal but not currently enrolled that special tasks in terms of outreach need to be done to get them into the programs that are available to them, because the LIP was an optional program, and so those 5 counties missed out on that transition opportunity. There are also some exempted populations that are allowed to go without insurance and not pay the individual mandate penalty, but might still benefit from insurance. So one, of course, is people earning less than the tax filing threshold. If you don't earn $10,000, there's no way you can pay a penalty because your penalty is your income minus the tax filing threshold. So that population may decide we're not going to buy insurance because we don't face a penalty, but they actually qualify for free Medi-Cal. So I think making sure that that population is reached out to and are brought into the system will be important. The other ones are groups that are joining Christian sharing ministries. I know in certain ethnic religious areas there's a very active marketing effort currently around saying, well, you don't have to sign up for Covered California. If you pay into this Christian sharing ministry, we'll pay some of your healthcare costs in the future, depending on how much you spend in the year, but you're actually given a certificate that exempts you from the individual mandate penalty, and the cost of buying into the Christian sharing ministry is cheaper than the cost of buying Covered California insurance for some people. So that population will think they're covered for some of their costs, but may be doing it to avoid the penalty, but are still basically left uncovered for really significant issues. And so if they're showing up in county emergency rooms and other settings, they're still going to cause an uncompensated care burden for many facilities. Then, of course, there are several groups that fall into hardship exemptions, including those with plan cancellations, that are allowed not to buy coverage, but may still find it affordable to purchase coverage in the exchange as long as they're reached out to adequately. So even after full implementation, we anticipate that about 3 to 4 million people will still be without insurance coverage. About 1 million of those people are undocumented. However, here at UCLA and UC Berkeley, we do a model called CalSIM, the California Simulation of Insurance Markets, and we've actually tried to integrate some of the new premiums that have been coming out from Covered California because they were released, a few months ago, to see what the response would be, and we're anticipating that the response should be better if people are making kind of objective economic decisions about what they're being offered and the subsidies that they're entitled to. Other undocumented people may technically be insured according to our current record keeping and through Medi-Cal, but they're actually on emergency Medi-Cal or other episodic sources of coverage. And so figuring out what to do with that episodically covered population and managing their healthcare needs and costs will be important as well. And then we have the remaining local low-income health programs and county indigent programs that won't have the same resources that they had before. There will be no federal matching funds coming in to fund their low-income health programs, and so those counties will have to figure out a way to stretch their resources as much as possible to care for the remaining uninsured in the midst of realignment at the county level. So, and there are also some new challenges in terms of how to provide care to those populations. Thinking about the county realignment issue and the fact that you still may see hundreds of thousands uninsured people coming into county emergency rooms in Los Angeles, let's say. There's also in the Affordable Care Act a reduction in disproportionate share hospital payments on both the Medicare side and the Medicaid side that could diminish the amount of money coming into safety net hospitals to defray the cost of uncompensated care. Now, the first 2 years of the cuts were delayed in the Patty Murray, Paul Ryan budget deal recently, but by 2019, there's still going to be a really significant, probably about a 50% cut in DSH that will be coming down that could hurt county and safety net hospitals' ability to kind of bear the brunt of the uncompensated care population. In addition, of course, DSH deals with Medicaid shortfall, and if Medi-Cal rates are stagnant and hospitals are taking losses on Medi-Cal rates, that's a problem as well. In the budget deal in the state, safety net hospitals, public hospitals, and university hospitals kind of have a 3-year period when there's 100% federal matching where they're getting cost-based reimbursement for their hospital days, but that could change in the future. And depending on what happens with the remaining uninsured, you could see problems with access there. Of course, we also have issues with Medi-Cal reimbursement and potentially issues with Covered California reimbursement if plans are kind of playing, driving a hard bargain with providers that they're trying to get into their network. So if they're trying to pay under the prevailing commercial rate and providers don't want to take that reimbursement rate, they might drop out of the network for either Medi-Cal or for the private insurance coverage. There's a temporary primary care increase for Medi-Cal due to the ACA that's in 2013 and 14 that could help people weather the storm a little bit, but that goes away in 2015. In addition, as part of this new budget agreement that Murray and Ryan agreed to, and then the $1 trillion omnibus budget reconciliation package that we're seeing moving through Congress now, there's an additional $1 billion cut to the Prevention Public Health Trust Fund, which includes workforce planning and investment in it as well. So workforce issues, reimbursement rates seem to be running at odds with the insurance expansion at this point. So I think we need to take a careful look at making sure there's reimbursement, fair reimbursement going to primary care physicians at the very least. And of course, the realignment formula at the county level is based on this idea that current users of county safety nets will shrink. They'll be replaced by newly insured individuals. We have to make sure that that's actually happening. Currently, we've seen lower enrollment among Latino populations, lower income populations that might currently be safety net users in Covered California, and we have to make sure that that isn't the standard set now and will continue into the future. Now, in terms of policy options, especially around the remaining uninsured, I think there's some opportunities here, and they've come up in the last legislative session and also in the current legislative session around building upon Covered California and Medi-Cal structure. So one area is that the California Endowment and Department of Healthcare Services through AB 82 are taking advantage of resources for outreach and enrollment. Covered California, for Medi-Cal specifically, Covered California is using their federal establishment grant money to do outreach and enrollment. So I think taking advantage of those resources when they're available will be really important to making sure Covered California and Medi-Cal enroll as many people as possible early on in the process and stabilize those insurance markets and improve people's health status and access to care. But there could also be, especially in California where the cost of living is higher, that additional tax subsidies for higher income groups, or additional penalties even for employers or higher income groups who decide not to buy insurance, could be instituted. One that comes to mind is AB 880, which was the idea that large firms that don't offer coverage and end up with people in Medi-Cal would actually be charged a fine for Medi-Cal beneficiaries who weren't offered insurance. And that's something that's not in the Affordable Care Act currently. Right now, an employer would not face a penalty if their employee signed up for Medi-Cal, even though they're saving thousands of dollars by not offering them insurance coverage. Another idea that came up recently, and it came up a couple years ago in a meeting with Will Dow at UC Berkeley, who thought, a parallel exchange that would be run through state-funded tax credits could take advantage of Covered California's investments and ability to contract with providers, but it could specifically be for people who are undocumented if there was an interest in doing state-funded tax credits or subsidies. And Ricardo Lara from Bell Gardens, who's a state senator, has kind of pushed this proposal recently, saying that a parallel exchange or some inclusion of state-funded tax credits for the undocumented through Covered California might be an option, as well as expanding state-funded Medi-Cal, or potentially putting more money into county indigent programs like low-income health programs that would care for the undocumented uninsured who are locked out of the other benefit changes in the ACA. And lastly, the big policy option I think that a lot of advocates are looking forward to is in 2017, the Affordable Care Act includes a provision, Section 1332, that grants waiver authority to actually plan and implement a new insurance model as long as you can prove equivalent outcomes, that it's budget neutral, and that you cover just as many people, where you could waive all of the requirements of qualified health plans, tax credits and subsidies, and the federal government would hand over the calculated amount of tax credits and subsidies that the population deserves, in essence, in that state, and the state could use it to provide a different model. They could do something more akin to a single payer model. They could use a different purchasing authority for that population, or they could merge it into other activities that might be going on with employer-based insurance and Medi-Cal and Medicare. And Vermont is exploring that issue and has already said they're moving forward in 2017 with their Section 1332 waiver proposal, and other states have that option as well. So with that, I want to wrap up, and I think we'll take questions and answers at this point. So thanks very much for listening.
Dr. Roby? Oh, I'm sorry.
Yes.
I think you were breaking up on my side. But we're going to go ahead and start the Q&A section. And we actually have quite a few questions from the audience members. And if any of you listening have a question, you can go ahead and type it in the chat window. To start off, Dr. Roby, we have a question from Paul. And he wants to know, why do the exchange plans pay for the doctor in medical rates? Even Medicare rates would be better than that. He says he's forced to go directly to the insurance company off the exchange because at least one of his doctors will not accept medical rates.
Right. So I think it depends on which plan you're talking about. So in some cases, the plans have been basically sending out letters to their current provider network and saying, we're willing to pay you 60% of what we typically give you for commercial products, for employer-based plans, let's say. And so, it is a lot closer to a Medi-Cal rate than a physician might like. Now, one thing that's occurring, of course, is that the Covered California plans have mirror plans outside of Covered California in the regular insurance market. So if you see a Kaiser Covered California plan, you can buy the same exact plan outside of the exchange at the same premium. You can do the same thing with Blue Shield. And my understanding is that Blue Shield has decided to align their outside exchange and inside exchange networks, whereas Anthem has decided to have an alignment between only the mirror plan outside of the network and the Covered California plan, but they're still offering higher premium, broader network plans outside of Covered California, designed at people who either want access to specific doctors or don't get insurance subsidies and therefore are willing to pay more for a plan outside of the individual market, outside in the individual market, and not participate in Covered California. So I think depending on the insurance plan, depending on the setting, that's probably correct. the idea is that the greater volume and lower payment might be worthwhile to some physicians, but I think that insurers are trying to exert their purchasing authority in a way to see what price they can get, and it'll probably level out over the next 3 years as insurers try to get an adequate network. If they're not able to get the doctors their consumers want, then there's pushback. And really, I think we're starting to see the world on the individual market side very much like it's worked in the employer side for many years, in that UCLA each year has some fight with an insurance company about who to contract with. And they often get dropped from a network, and they come back in the middle of the year, and employees are upset, and you end up with those types of negotiations going on. So it really will be up to consumers to tell the plans that they're signing up for who they want in their network, and talk to their providers about signing up for the network. And so if providers feel like it's worthwhile to keep a certain number of patients that they might lose if they don't participate in an exchange plan, they might sign up. And I think right now there tends to be this knee-jerk reaction to, they're asking me to take lower payment for these covered California plans, but really there should be some equilibrium reached at a certain point. And I think consumers, because they're the ones buying the plans, need to be forceful with their providers and with their health insurers about who they expect to be in their network and why they're not buying a plan from them if the network is too limited.
Great. We have another question from John, and he asks, it seems like the coverage requirements sometimes limit consumer choices unreasonably. For example, requiring prenatal care or contraception for people who are beyond childbearing age. Is there a prospect for providing more choice in coverages in the future?
I mean, the decision overall in the Affordable Care Act was to maintain a statewide standardized essential health benefits package that will be required for the individual market in and out of the exchange, and the small group market, so employers with fewer than 50 employees in and outside of the exchange. With the idea that insurance companies before were basically risk selecting and cherry picking their population by not including prescription drug coverage, not including maternity benefit, not including things like that, and mental health care. So really, in essence, what we're seeing now is a stabilization of the benefit package, so people are able to shop around knowing that the benefit package is the same. But I think it's a very slippery slope to think about, okay, I don't want to pay for prenatal care because I'm a 40-year-old male. On the same way, you could, a 28-year-old female who doesn't care about prescription drugs could say, I don't want to pay for those prescription drugs, but I do want prenatal care. And people don't have a very good idea of what their actual healthcare risks are in a given year. They don't know what they're going to use. And so I think having a standardized benefit package is helpful in making sure people can compare their options. But people have to get used to the idea that there are lots of benefits that they use that other people don't use, and there are lots of benefits they don't use that other people do use, and we're all contributing to this common pool of resources that's allowing the health insurance market to be stable and be understandable for everyone.
Another question comes from Sandhya, and she wants to know about the legal permanent resident requirement. Do people have to be in the U.S. for 5 years as a legal permanent resident, or could the 5 years include other legal status, maybe under another visa, and combined with also being a permanent resident?
So it would be having a green card and being a legal permanent resident for 5 years. So it would be any time after a visa. And this will be an issue that comes up if immigration reform moves forward, because of the fact that it creates this kind of odd category of legal provisional status that people would be parked in for 8 years. Then they would become a green card holder and have to wait 5 years before becoming a citizen. So anybody who has waited out the 8 years through legal provisional status would then have to wait 5 more years to qualify for Medi-Cal, but they would be able to use the insurance subsidies available in the exchange while they're a legal permanent resident for less than 5 years and get those wrap payments.
We have a question from Connie, and she is asking, who will cover patients who qualify for coverage through Medi-Cal or private insurance but choose not to get insured?
I'm sorry, I'm not sure I understand the question. So you said they qualify but choose not to. So I mean,
Right.
they're still going to be uninsured. You can't force anybody to sign up for a program that they don't want to sign up for. They will face the individual mandate penalty potentially, which is $95 per person in the household, up to, at least in 2014, up to $285 or 1% of income. It goes up in 2016 to $695 per person, max of $2,085 or 2.5% of income. So if people are willing to pay that penalty, they're still contributing to the system. It's kind of a pay or play mentality, but they're going uninsured. So then if they're uninsured and they're going to the ER, if they're going to a community health center, those ERs and community health centers are losing money on that case. They might be billing them. They might not be getting reimbursed. And so it'll be up to county indigent care programs. It'll be up to those hospitals and community clinics to try to sign them up for Medi-Cal coverage and try to get them insured. So there's quite a variety of ways that an actual provider can try to deal with it. But the fact of the matter is, if they're walking in uninsured, it's going to be very similar to how it works now, with the fact that with EMTALA, the Emergency Medical Treatment and Active Labor Act, you have to stabilize a patient. You can't do a wallet biopsy to turn them away. And really, it'll be an issue of convincing them, or at least explaining why it's important that people get insurance, but also provide them with the knowledge and tools to actually sign up. Because I think a lot of people, they may make a calculated decision that they're not risky this year, but they see the relevance of having insurance and they might sign up for a lower level plan. But there are lots of people who just don't know what's going on. They're confused by the whole thing. And there's a poll recently that came out and said that 70% of the uninsured really didn't understand their options under the Affordable Care Act. And I think education is probably more important than trying to figure out a way to keep them out of the market. So I think we'll see what happens in the next few years, but it underscores the need for a robust safety net continuing on for the next few years at least.
Dr. Roby, we're running out of time, but I do want to ask one last question. We had a great discussion today about what's happening in California. Here, the legislature and the governor agreed on both the Medicaid expansion and the creation of a state-run health insurance marketplace. What do things look like in other states, especially those who either opted out of the expansion or are still kind of considering it?
Right. So the federal government has established a bit of a track record of being flexible with states that are considering expanding Medicaid, but don't want to do it as described in the ACA. So they just approved a waiver to the state of Arkansas to use Medicaid dollars to enroll their population into the private health insurance exchange rather than offer coverage through Medicaid. So that flexibility has opened up the door to Iowa, Pennsylvania, other states trying to do something similar using a private market model through the exchange to answer their Medicaid expansion because it's more politically feasible. In other states that aren't doing that, they've decided not to do the Medicaid expansion, like Texas, for example. They actually end up with people under 100% of poverty who are childless adults not being able to get Medicaid at all. And so they're probably likely to see an increase in uninsurance over the years as time goes on, where people in California will be far more likely to be able to qualify for Medicaid. So we may end up 5 years from now with quite a different story in terms of how the uninsured are split up throughout the country. California and Texas have always been running neck and neck in terms of uninsurance. And it looks like California will now have a much better insurance rate, and Texas will still have lots of low-income people who are uninsured and unable to access care easily.
Thank you so much, Dr. Roby. We're out of time, so we have to wrap it up there. But thank you, everybody, for joining us. And please join us on Thursday, February 13th, for the next webinar, and we're going to continue the conversation with Dr. Stephen Wallace, who will discuss the impact of the Affordable Care Act on undocumented immigrants in a talk that's titled Undocumented and Uninsured, Immigrants Under the Affordable Care Act. And if you've missed any of our previous webinars or you want to watch a recording of this one, you can go to the Fielding School of Public Health's website. That's ph.ucla.edu, and they are all archived there. And please allow a few days for this webinar to be posted. Thank you, everybody, and have a great day.